So can we start? So can we start? Okay, so today I am planning to cover mainly paper 1, okay, in pathology. So in paper 1, there are certain things that you have to keep in your mind. Number 1, it covers general pathology, right from chapter cell health, unit and disease to environmental disorders, childhood disorders. I think it covers up to chapter 8 or chapter 9 in your Robbins textbook. Then a very important topic, that is systemic pathology, okay, that is paper 2. Then hematology plays a very important role. It is always, what to say, a high yield topic in paper 1. So without wasting much more time, I am straight away going into first chapter, where you are having your pen, paper, okay, all those, so that you can take note of. Make sure you okay, CRISPR is a gene editing technology in your latest edition of Robbins. So that is a much known question. Second question is extracellular matrix. Okay, various composition of extracellular matrix. Third question, stem cells. Fourth question, transforming growth factor beta. Fifth is hepatocyte growth factor, so called as scatter factor. Okay, so these are. Make sure you have covered what is apoptosis, what is intrinsic pathway, what is extrinsic pathway, okay, what is necrosis, how will you differentiate apoptosis and necrosis, what are the different patterns of necrosis, that is coagulative necrosis, liquefactive necrosis, caseous necrosis, fat necrosis. Remember, acute pancreatitis is fat necrosis, okay. So in chapter 1, once again I am repeating, in chapter 1, CRISPR, transforming growth factor beta, stem cells, locations of stem cells, hepatocyte growth factor, okay, so called as scatter factor, okay. So I have some slight network issues, so in between, if you are having any problems, no, please put it in the comment box so that I will repeat those topics again, okay. Then so that's about chapter 1. In chapter 2, what all I was telling, intrinsic extrinsic pathway of apoptosis. Remember, what are the different patterns of necrosis? Coagulative necrosis, liquefactive necrosis, caseous necrosis, fat necrosis. Acute pancreatitis, remember, it is fat necrosis. Once this is done, what other questions you can expect from chapter 1 as cell aging. Okay, cell aging is a very potential question. Very rarely it has been asked in your university supplementary exams. So please make sure you are studying cell aging. Cell aging, very important point, sirtuins. What are sirtuins? They are histone deacetylases group of molecules. Okay, what are the functions of sirtuins? Very important. Then in the chapter of cell injury, they will ask you what are the examples of hyperplasia, hypertrophy and metaplasia. It is a very potential MCQ questions. Okay, which of organs shows hyperplasia, then which all organs shows hypertrophy. Okay, metaplasia, intestinal metaplasia, that is corner metaplasia as well as squamous metaplasia. Okay, please don't say that to say all questions again and again, okay, because the session will get more and more long. Okay, for the last one more time I am telling, chapter 1, CRISPR, transforming growth factor beta, then scatter factor, stem cells and its location. Okay, then coming into the other important questions, what is dystrophic calcification, what is metastatic calcification? Dystrophic calcification and metastatic calcification, difference is important, examples are important. Another most important question, a must-known question, is Samoma bodies. In which all diseases you will find Samoma bodies? Examples are a very potential MCQ question. Another important question which I would like to mention is regarding, the examples I have already told it, hypertrophy, hyperplasia, metaplasia, okay, all those. Then atrophy, okay. So all these are cellular adaptation. Then a very potential question, ferroptosis, pyroptosis, necroptosis. Out of these three, any one, they are frequently asked either in your main exam or in your supplementary exam. They are asking this again and again: necroptosis, pyroptosis, and ferroptosis. So with this, chapter 1 is finished. Chapter 1, potential MCQ areas, examples of that cellular adaptation, markers. Remember CD95. CD95. It is a marker of extrinsic pathway of apoptosis, whereas annexin 5, it is a marker of intrinsic pathway of apoptosis. Again, a very, very important MCQ. So that is done with chapter 2. Then in chapter 3 comes inflammation and tissue injury. The most important essay question you can expect from the chapter of inflammation. They will give you a case scenario of a patient who comes with a history of road traffic accident, and following that he is having multiple injuries. But in his hand or in his arm, there is a well, or per se, a clean cut injury. What type of wound healing it will undergo? Clean cut superficial injuries always heals by primary intentions. Ulcerated wound always healed by secondary intention. So the most important question, tissue repair. Remember, transforming growth factor beta, VEGF, vascular endothelial growth factor, all these plays a very, very important role. That is extremely another important question. Primary intention, secondary intention, wound healing, again is another important question. Primary intention, secondary intention. Then comes, what is the role of TGF beta? What is the role of matrix metalloproteinases? Okay, what is the role of VEGF in tissue wound healing? Again, that is another important question. Once that is done, the same question they will give, like the patient comes with pain in the right iliac fossa associated with fever. So right iliac fossa, fever, pain, this in an young male, what you will suspect? You will be suspecting case of acute appendicitis. So here comes the question. What is acute appendicitis? It is a type of acute inflammation. What are the important events of acute inflammation? Question number 1. And a second essay that can be asked from the same question, what are the important cytokines and inflammatory mediators? A very beautiful table is mentioned in Robbins. Please make sure whatever book Harsh Mohan or Ramdas Naik that is very well mentioned, please make sure you are reading those tables. What are the important functions of cytokines? What is the role of histamine, bradykinin, prostaglandin, different prostaglandins? Very, very important. One MCQ sure from this table. Then second thing, chronic inflammation. Okay, what are the stages of chronic inflammation? Chronic inflammation, best example, they will give you a clinical history of tuberculosis. A patient comes with evening rise of temperature, weight loss, cachexia, cough, productive sputum, or cough with blood streaks. All these are characteristic clinches of tuberculosis. I am again repeating, stressing again, tuberculosis is a very, very important potential question for your university exam. Tuberculosis, primary tuberculosis, secondary tuberculosis, the Gons complex, Rankis complex, okay, everything I have discussed in detail in my YouTube video, and you can go through the playlist infectious diseases, okay, malaria, syphilis, tuberculosis. 3 are very potential question. Make sure you are reading some points at least about this, okay. So that is chronic inflammation. So acute chronic inflammation, wound healing, inflammatory mediators and roles. Primary intention, secondary intention, role of TGF beta, role of VEGF. All those are very, very important questions you must know in the chapter 2 inflammation. Once that is done, go for chapter 3. So chapter 3 or the next chapter is hemodynamics. In hemodynamics, the most important question that I am expecting this year is fat embolism. A patient who comes with road traffic accident with history of shaft of femur fracture, presenting within 6 hours with episodes of tachypnea, altered consciousness, CNS, CVS, RS manifestation. You have to immediately think about fat embolism. Okay, fat embolism, you must know what are the presenting features, what is the pathogenesis, okay, and what is the microscopic features. Okay, this is it. It is actually given only what small in your textbooks, but it is remember, it's a potential question. Then another important thing is white thrombus versus red thrombus. Differentiation is important. Antemortem clots versus postmortem clot, again differentiation is important. Then a very, very potential essay question from hemodynamics. Without this study in this question, you can't exam, that is shock. So in shock, there will be definitely a clinical case scenario of a patient who is coming with history of fever, hypotension, tachypnea. Always think about shock. If you are confused whether it is hypovolemic shock or cardiogenic shock or septic shock, just mention your answer as shock. That will be enough. You will be given marks. Or if you are sure, okay, there is any history of prior infection, there is history of fever, there is leukocytosis, in such a case, make sure you are, or you can write that it is a case of septic shock. In all other cases, you mention it is just shock. Okay, that's done. Okay. So in that chapter, fat embolism important. If possible, study about Ben's disease. Ben's disease, also called as decompression sickness, Casson's disease. So again, it is a very, very important question. That is deep sea drivers. I think 2 years back in your CBME batch, they have asked this question: Ben's disease or Casson's disease. Okay. So once that is done, we will go for the next chapter, genetic disorders. And as far as MCQ point is concerned, I am once again repeating, in inflammation chapter, that table is important. Okay, what table? Inflammatory mediators and their action. What all mediators cause vasodilatation, what all cause platelet aggregation, what all cause vasoconstriction, what all increases vascular permeability, what is responsible for pain, okay, bradykinin, substance P, all those are important. Then coming into the chapter of hemodynamics, again, what is that? Chicken fat appearance, then lines of sand, what are the composition of lines of sand, okay, then amniotic fluid embolism, then what are the interleukins, interleukin 1, 6 and TNF alpha. These are the 3 important cytokines that are involved in what? The pathogenesis of shock. That is important. Out of gram, I am asking a question, out of gram positive and gram negative bacteria, which is having higher propensity to produce septic shock? Can you post it in the comment section? Out of gram positive and gram negative, which is having more propensity to produce septic shock, whether it is gram positive or gram negative, please post your answer in the comment box. Okay, see, everyone is writing the answer as gram negative. Okay, maybe because of the textbooks mentioned, but Robbins clearly mentioned that it is gram positive organisms which causes more chances of septic shock than gram negative. Yes, it is why you are telling gram negative means endotoxins. Endotoxins are present in gram negative, but just okay, correct yourself, gram positive, out of gram positive and gram negative, even not only in Robbins textbook, even in textbooks of medicine says that it is gram positive organisms are having more propensity to cause septic shock than gram negative organisms. Okay, so that is about hemodynamics and chapter. And another one important question which I am expecting from the chapter hemodynamics is amniotic fluid embolism. Okay, it is a bit small topic one. If possible, you mention. Okay, if possible, you read in from the textbook, or else fat embolism must, Casson's disease must, septic shock must. Septic shock I am stressing again and again. Whatever be the clinical features, you must be able to make it a proper diagnosis of shock. Okay, if you are doubt whether it is hypovolemic shock or septic shock, just write it is shock. Okay, if your diagnosis is correct, you can write the rest everything. Fine. So that is done. Then coming to the chapter genetics. Yes, genetics is a chapter which is full of amniotic fluid embolism. See, amniotic fluid embolism, I'll explain in just 1 minute. They will give a history of a pregnant female coming to the labor, delivered a baby. Immediately after the placenta is delivered out, the patient goes into shock. Immediately after delivery of the baby, the patient goes into shock. Remember, postpartum hemorrhage can also present like this. How to differentiate postpartum hemorrhage is a type of hypovolemic shock. Okay, in hypovolemic shock, there will be what? Hypotension, there will be tachycardia, there will be tachypnea and everything. In amniotic fluid embolism, the amniotic fluid which is present, where it is present within it is just going to cover the baby, right? Okay, it is completely encased by the amniotic membrane. So when we rupture the amniotic membrane and deliver the baby, immediately, spontaneously, within seconds, the mother goes into shock. If this is a saline history present, you can go for amniotic fluid embolism. In amniotic fluid embolism, on histopathological biopsy, you will find that there are a lot of squamous epithelial cells. What are the squamous epithelial cells? They are derived from the fetal membranes. This is a characteristic clinic. and the patient will also have neurological deficit. That means the patient will have altered consciousness. Okay, the patient will start blabbering something. Why? Because this is going to, this amniotic fluid embolism, no, it will go and affect the central nervous system also. So this is about amniotic fluid embolism. Okay, coming into the chapter of genetics, what all you have to study? To answer MCQs, you must study examples of autosomal dominant, recessive, X-linked dominant and X-linked recessive. Especially X-linked recessive and X-linked dominant. If you study, you can answer most of the questions. Why? Because the examples of X-linked dominant and X-linked recessive diseases, it is very less, right? So it will be very easy for you to answer rest of the question. MCQs are, a lot of MCQs are they expecting from the chapter genetic disease. Why? Okay, once again I will repeat, sorry, there is a network issue. Okay, so if you study the examples of X-linked recessive and X-linked dominant, it will cover most of the questions. Okay, very important. X-linked dominant, X-linked hypophosphatemic rickets, Rett syndrome, Alport syndrome. These three examples you must know for X-linked dominant. X-linked recessive, G6PD, color blindness, hemophilia. I am asking one question. Hemophilia A and hemophilia B are X-linked recessive. When they ask what is the inheritance pattern of hemophilia C, what should be your answer? Yes, what is the inheritance pattern of hemophilia C? Remember, hemophilia C is inherited autosomal recessive. It is not X-linked recessive, it is autosomal recessive. Yes, very good. Narasimhan, very good. It is autosomal recessive. Whereas hemophilia A and hemophilia B, it is X-linked recessive. Hemophilia C is autosomal recessive. Okay, very, very important question. Then, another important question is, that is short note question expected from the genetics chapter. Start noting down. Number 1, Marfan syndrome. Number two, Ehlers-Danlos syndrome. Ehlers-Danlos syndrome. Okay. Number 1, Marfan. Number 2, Ehlers-Danlos syndrome. Number 3, Huntington's disease. Huntington's disease. Number 4, familial hypercholesterolemia. Familial hypercholesterolemia. I am expecting Marfan syndrome this year. Marfan syndrome, the patient will be tall stature with arachnodactyly, long feet, long digits, superior lens dislocation, serious problems like aortic dissection. Okay, very, very important. Serious problems like aortic dissection. So these are important questions. Then familial hypercholesterolemia. Familial hypercholesterolemia. Then they are going to ask a question: Prader-Willi syndrome versus Angelman syndrome. Prader-Willi syndrome versus Angelman syndrome. That is, they are examples of gene printing associated with maternal and paternal deletion of chromosomes. Prader-Willi syndrome, what are the features of Angelman syndrome? It is again a very, very important potential question. Okay, fine. Once that is done, we will go to the techniques. Techniques are again an important question. Out of that, PCR, polymerase chain reaction. What are the steps of polymerase chain reaction? You will study either in pathology or in microbiology. In microbiology, it is explained in detail. Make sure you are studying polymerase chain reaction. It is important in microbiology also. Polymerase chain reaction. Then second important question is FISH, fluorescent in situ hybridization. What is FISH? What are the roles of FISH? What are chromosomal abnormalities? Chromosomal abnormalities like aneuploidy, translocation. We have 922 Philadelphia chromosomal translocation in chronic myeloid leukemia. Yes, so the investigation of choice in chronic myeloid leukemia is FISH. It is the best test to find the translocation. Then, okay, what are the limitations of FISH? Advantages and disadvantages of FISH. Uses of FISH. Okay, technique of FISH. Okay, just at least make sure you are studying some 5 points so that you can write in a short note question. Then another question they are going to ask is NGS, next generation sequencing. Next generation sequencing, NGS, again a very important potential question. NGS, next generation sequencing. Okay, NGS, next generation sequencing. So all inheritance patterns with examples important. Marfan, Ehlers-Danlos important. Familial hypercholesterolemia important. Huntington's disease important. Prader-Willi versus Angelman's disease important. FISH important. Then Next generation sequencing important. Polymerase chain reaction and its steps important. In genetics, I am expecting Marfan syndrome with the case scenario I have already told. Okay, there is a tall stature, superior lens dislocation, all those things. Then familial hypercholesterolemia can be asked. Then this genetic techniques can be asked. Okay, fine. Let us go for the next chapter. See, genetics, try to read the inheritance pattern, all examples. You can get one question right in your MCQs. Coming to disorders of immune system, then neoplasia. See, both chapters are very, it's like a large chapter. First question, let us discuss about the essays in the chapter of immunity. Number one essay is systemic lupus erythematosus. 22-year-old female coming with history of photosensitivity, malar rash. Your diagnosis should be systemic lupus erythematosus. Make sure you are studying all the anti-nuclear antibody patterns. We have different patterns now: diffuse, syndromeric, speckled, nucleolar, and in what diseases these patterns are present. Very potential MCQ. Make sure you are studying each pattern with example. SLE, remember pathogenesis, clinical features. Remember the kidney manifestations of SLE. We have different grades now. Yes. Make sure you are reading that also. Second essay, expecting HIV. HIV you can study from microbiology. With that you can write an essay in pathology also. Okay, HIV. Third question, graft rejection. Hyperacute graft rejection, acute graft rejection, chronic graft rejection. Make sure you study this. And another important question, GVHD. What is GVHD? Graft versus host disease. Again, very important. Then, must-known question. Like SLE, you must know what is type 1, type 2, type 3, type 4 hypersensitivity reactions with their examples. Tables are given very beautifully in Robbins. Make sure you are studying examples of all these hypersensitivity reaction. One MCQ must. Type 1 is asked as an essay question. Type 4 is also asked as an essay question. SLE, remember, what type of hypersensitivity reaction is SLE? Post-streptococcal glomerular nephritis, Arthus reaction, serum sickness, all these are type 3 hypersensitivity reaction. Antigen antibody deposition reactions, immune complex deposition reactions. Type 4 is responsible for what? Granuloma formation, tuberculosis. Okay, yes. So make sure you are studying examples of all these things. Then short note question expecting are systemic sclerosis and Sjogren syndrome. Systemic sclerosis and Sjogren syndrome, very important. Another short note expecting is major histocompatibility complex, MHC 1 and 2. I think that you will study in your microbiology also. Make sure you are reading from pathology. Okay, with that knowledge itself you can write in pathology. And another important question, what is central tolerance and what is peripheral tolerance? Okay, so these are the mechanisms normally used our body, okay, to prevent autoimmune disorders. So whenever there is a defect in the central and peripheral immunity, central tolerance and peripheral tolerance, defect in central tolerance and peripheral, they will it will cause us autoimmune disorders. Okay, so make sure you are studying central tolerance and peripheral tolerance. Okay, yes, so far is it okay? Yes, can anybody put some reactions in the comment box? Fine. Okay. So SLE, Sjogren, systemic sclerosis, HIV, graft rejection, graft versus host disease, different hypersensitivity reaction, autoimmunity. Then next, what else? The examples of hypersensitivity reaction, MHC1, MHC2, all those are important. Fine. Then, last but not the least question in immune system is amyloidosis. What is amyloid? What is primary amyloidosis? What is amyloidosis? Very, very important. There is a table given in Robbins in what type of diseases, what type of amyloid will be deposited. For example, Alzheimer's A beta amyloid, medullary carcinoma of thyroid, it is calcitonin type of amyloid. Okay, beta 2 microglobulin in patients who are undergoing hemodialysis. Very, very important, potentially expecting MCQ this year. What type of amyloid is being deposited in hemodialysis associated type of amyloidosis? It is beta 2 microglobulin. What is AL? That is primary amyloidosis, occurs in multiple myeloma. Secondary amyloidosis is reactive amyloidosis, AA type. Okay. Then, what type of amyloid is deposited in familial Mediterranean fever? It is ATTR, that is transthyretin type of amyloid. That wonderful table, please make sure you study. What are the histopathological features of amyloidosis? Very, very important. You know that Congo red stain, thioflavin T, thioflavin S, polarizing microscopy. Very, very important. In normal light microscopy, amyloid appears pinkish. In polarizing microscopy, amyloid appears apple green birefringence. Okay, apple green birefringence occurs in polarizing microscopy. It has been asked in your previous year MCQ. Okay, it is in polarizing microscopy we are getting apple green birefringence. Light microscopy, pinkish hue. Okay, fine. So with that, we will go for next chapter, neoplasia. Metastasis. What is angiogenesis important? What are the steps of metastasis important? How will the question will be? A 50-year-old female comes with lump in the breast. It was diagnosed to be carcinoma of the breast. The patient have complaints of backache during the due course of the disease. Investigation shows what? Investigation shows metastasis to the vertebra. What is the underlying mechanism? Yes, why, how the breast cancer patient develops vertebral pain? It is because of metastasis. What are the steps of metastasis? Important. Okay, what are the steps of metastasis? Important. Two important genes which are known to promote metastasis. I am typing in the comment box. Okay, please make note of these two genes. One is snail and another one is twist. Okay, snail and twist. These two are the genes which promote metastasis. Very, very important. I am expecting this gene. Okay, they help in epithelial mesenchymal transition. They degrade the basement membrane. They help in degradation of basement membrane with the help of matrix metalloproteinases and take the tumor cells to different parts of the body. Okay, so metastasis, steps, angiogenesis, very, very important. Second question, P53 tumor suppressor gene. It is associated with a syndrome called Lee-Fraumeni syndrome, which is associated with osteosarcoma, breast cancer, thyroid cancer, okay, leukemia. So many multiple syndromes, cancers occurs in Lee53. You must know what is the governor of cell cycle, what is the guardian of the cell cycle. Yes, next important tumor suppressor gene, retinoblastoma. In retinoblastoma, make sure you are studying what is Knudsen's two-hit hypothesis. Once an essay was asked, a female or a male with compliance of retinoblastoma on complete removal of the eyeball. Now, his brother has present with some swelling in the bone, in the knee joint. Most probably it is osteosarcoma. So what gene is involved? It is retinoblastoma gene. Remember, the second most common cancer which occurs in retinoblastoma patient is osteosarcoma of the femur. Okay, then tumor suppressor gene TP53 is important. At which point of the cell cycle? That, you know, G1S checkpoint, the P53 and retinoblastoma will act and it prevents. Okay, they are tumor suppressor genes. Then another important question, you must know what is the chromosomal location of TP53 and what is the chromosomal location of retinoblastoma. Then another important question, you must know what is Knudsen's two-hit hypothesis. Knudsen's two-hit hypothesis. Okay, then short note I am expecting from the chapter neoplasia. Tumor markers, number 1. Number two, indications of FNAC in thyroid, FNAC of breast. All this PDF I have already uploaded in my WhatsApp group. FNAC of thyroid, FNAC of the breast, liquid-based cytology. Tumor markers, PNS, paraneoplastic syndrome. What is the most common paraneoplastic syndrome which occurs in squamous cell carcinoma of the lung? It is SIADH. What is the most common paraneoplastic syndrome which occurs in, what I told, SIADH is associated with small cell carcinoma of the lung. Squamous cell carcinoma, the most common paraneoplastic syndrome is hypercalcemia. Okay, hypercalcemia. You must know what are the tumor markers. Remember, tumor markers are screening tests. They are not confirmatory tests. They are screening tests. They are used to assess the prognosis of cancer progression. Liquid-based cytology, FNAC thyroid, FNAC breast, important. Hamartoma versus choristoma. Hamartoma versus choristoma. Another important question. Hamartoma versus choristoma, important. Hamartoma versus choristoma, important. Okay. So tumor markers, hamartoma, choristoma, TP53, retinoblastoma. Remember the case scenario. Retinoblastoma with osteosarcoma. Remember that case scenario. Then metastasis case scenario is important. Paraneoplastic syndrome cancer is important. Hamartoma versus choristoma is important. What are the hallmarks of what malignancy? What are the hallmarks of malignancy? Important. Okay, the so-called hyperchromasia, basement membrane invasion, increased nuclear cytoplasmic ratio, all those are very, very important questions. Okay. Fine. What are the different mechanisms used by tumor cells? Okay. Evasion of apoptosis, loss of self-regulation, failure of tumor suppressor gene. Some 7 steps are there, which is mentioned in Robbins. Make sure you are studying the 7 steps. Then, what is Warburg effect? Warburg effect. What is Warburg effect? What is oncometabolites? Potential question expecting this year. Oncometabolites, which is mentioned in your 10th edition of Robbins. What is oncometabolites? What is Warburg effect? Okay. Yes. Then coming to the next chapter, after neoplasia, infectious diseases. Malaria, syphilis, tuberculosis. Must. Malaria, male or female presenting with complaints of high-grade fever, native of states like Bihar, Chhattisgarh, Jharkhand, coming with altered history of consciousness, dark colored urine, same question asked in your university exam. Black water fever, okay? Yes, yeah, very carcinogens. Carcinogen, what question they are going to ask is chemical carcinogenesis. Chemical carcinogenesis. Chemical carcinogenesis. Carcinogens are going to cause malignancy. And carcinogenic agents and the corresponding cancer is important. For example, benzene causes leukemia. Aniline dyes causes bladder carcinoma. Asbestos causes lung carcinoma. Okay. Then radon xenon gases causes lung carcinoma. Aflatoxin causes hepatocellular carcinoma. Organisms and cancers. Opisthorchis clonorchis causes cholangiocarcinoma. Hepatitis B and C causes hepatocellular carcinoma. Human papilloma virus causes anogenital carcinoma. Cervical carcinoma. Lip and oral cavity carcinoma. Head and neck carcinoma. Esophagus carcinoma. See, human papilloma virus causes a lot of carcinomas. Okay. So carcinogenic agents and cancers. Organisms and cancers. H. pylori causes gastric adenocarcinoma. H. pylori also causes maltoma. Epstein-Barr virus causes nasopharyngeal carcinoma. It causes Hodgkin's, non-Hodgkin's lymphoma. Okay. NK cell lymphoma. NK cell lymphoma is called as midline granuloma. Why? Because this lesion occurs in the nasal septum, and it also covers the mid of the face. That is why it is called as nasal cell granuloma, T or NK T cell granuloma. All these are caused by Epstein-Barr virus. So organisms with carcinogenic cancer, all those are potential questions. Then infectious diseases, I have already told you: syphilis, malaria, tuberculosis. Malaria case scenario I have already told. Then tuberculosis case scenario already told. Syphilis, unprotected sexual worker come with painless indurated ulcer over the penis. Diagnosis: syphilis. What is the important histopathological finding in syphilis? Gamma, syphilitic gamma. Primary syphilis, secondary syphilis, tertiary syphilis. You would have studied this in microbiology, but remember, gamma is a histopathological change you've seen in syphilis. In syphilis, there is no neutrophilic infiltration. There is lymphoplasmocytic infiltration into the tissues. Okay, in histopathology, you will be seeing lymphocytes and plasma cells. Neutrophils are not involved in syphilitic lesions. Okay, that's about infectious diseases. Coming into the chapter environment diseases. In environment diseases, make sure you are studying lead poisoning. Make sure you are studying cadmium poisoning. Make sure you are studying iron poisoning. Make sure you are reading obesity. Lead poisoning, iron poisoning, obesity. Lead poisoning, iron poisoning, obesity, cadmium poisoning also. Occupational disorders, occupational cancers. In occupational cancers, you can write about lung cancers caused by asbestosis, bicyanosis, bagasosis, okay, berylliosis. All those are again potential questions. That is about environmental disorders. Remember obesity, boy, always watching TV, always eating snacks, okay, body mass index 35, 40. What's your diagnosis? Obesity. Remember adiponectins, leptins. What are the functions of adiponectins? What are the functions of leptins? MCQ questions in obesity. Once that is done, go for infant disorders and diseases of childhood. Potter's sequence is MCQ. Potter's sequence is MCQ. What are the components of Potter's sequence? What are the components of Potter's sequence? I hope you are all noting these questions. Okay, so at the end of the session, you can just see your textbook. Potter's sequence is important. Potter's sequence is important. Neuroblastoma, important. Cystic fibrosis. A mother brought a child whose sweat is salty or who is salty to taste. Okay, with history of bowel obstruction, meconium milius, infertility in adults, absent vas deferens, nasal polyps, increased sodium and chloride in the sweat, decreased exocrine pancreatic enzymes. All these characteristic of cystic fibrosis. Mutation in cystic fibrosis transmembrane regulator gene, which affects chloride transport in the body. Chromosome 7q, CFTR gene. Okay. Alpha-1 antitrypsin deficiencies associated with pan-acinar emphysema, liver lesions, chromosome number 14. Alpha-1 antitrypsin, chromosome number 14. Cystic fibrosis, chromosome number 7. Two important questions. Neuroblastoma, very, very important question. Neuroblastoma, very, very important question. Wilms tumor, very, very important question. Retinoblastoma, very, very important question. Retinoblastoma, neuroblastoma, Wilms tumor, cystic fibrosis. Make sure you are studying these 4 questions from the chapter infancy and childhood disorders. Okay, cystic fibrosis, retinoblastoma, Wilms tumor, and okay, Wilms tumor, nephroblastoma, retinoblastoma, cystic fibrosis. Make sure you are studying these 4 questions. Potter sequence components important, MCQ. Chromosome number cystic fibrosis 7. Alpha-1 antitrypsin, chromosome number 14. Done. Mechanism of oncogene activation I have already told that. Okay, TP53, retinoblastoma, the 7 steps in which malignancy occurs. Okay, all those comes there. See, Neoplasia immunity chapter, don't compromise for any questions. Try to read maximum number of questions because in paper 1 you will get, after hematology, the maximum number of questions you are going to get is from immunity and neoplasia. First maximum number of questions from hematology. Can we go to hematology? Okay. Okay, hematology. I'm starting with RBC disorders. RBC disorders. Make sure you are going through all the case scenarios of RBC, WBC, and platelet disorders which I have uploaded in the group. Any question can be asked. They have once asked sickle cell anemia, thalassemia, idiopathic thrombocytopenic purpura. Okay, all these are very, very repeated questions. Don't compromise for any questions. G6PD deficiency. Okay, everything. So I'm going to start with RBC. Number 1, iron deficiency anemia. Female coming with history of EC fatigueness, palpitations, hemoglobin less, MCV less, MCHC less, less RBC count, all those. Microcytic hyperchromic anemia, iron deficiency anemia. Second question, thalassemia major. Male who is completely dependent over transfusion. Okay, completely dependent on a transfusion. Now coming with history of extramedullary hematopoiesis, splenomegaly, thalassemia major. Remember, thalassemia major occurs in less than 10 years. Okay. Beta thalassemia minor and intermediate presents a bit late. Sickle cell anemia disease proper occurs less than 10 years. Trait occurs later. 20-year-old, 26-year-old coming with complaints of dactylitis, chest pain. What are these? Blurring of vision. These are symptoms of vaso-occlusive or painful crisis of sickle cell anemia. Remember, sickle cell anemia, thalassemia, iron deficiency anemia. Strict vegetarian diet person coming with history of numbness, macrocytic anemia, high MCV, hemoglobin almost normal, vitamin B12 deficiency, megaloblastic anemia. A Mediterranean person coming with history of drug abuse, following that he has history of dark colored urine. Males, only males are affected in G6PD because it is excellent. It is G6PD deficiency. Bite cells are important, schistocytes are important, blisterocytes are important. Sorry, not schistocytes, bite cells and blister cells. Okay, in G6PD deficiency. Mediterranean person, male, always males. History of fava beans intake, all those are precipitating factor. All these are precipitating factor for G6PD deficiency. A child coming with splenomegaly, gallstones, then hemolytic anemia. Yes, very good. Primaquine, nitrofuranilic acid. Okay. All these drugs precipitate G6PD. Male, a child coming with splenomegaly, gallstone. His father also suffering the same complaint from northwestern states like Rajasthan and all history. Think about hereditary spherocytosis, autosomal dominant pattern. Okay, ankyrin mutation. It is ankyrin which is the most common mutation in hereditary spherocytosis. Spectrin mutation most commonly occurs in hereditary elliptocytosis. Two important MCQs. Clinical features important. Osmotic fragility test important. Remember, for sickle cell anemia, thalassemia, all those, we will go for HPLC, high performance liquid chromatography, which is a gold standard test. Remember, NESTROF, naked eye single tube osmotic fragility test. Okay, that is NESTROF. NESTROF is a screening test for thalassemia. It is a screening test for thalassemia, not confirmatory. Confirmatory always HPLC. Sickle cell anemia, sodium metabisulfate test. EMA, eosin 5 methylenamide, okay, or flow cytometry. All those are confirmatory diagnosis tests for hereditary spherocytosis. Then autoimmune hemolytic anemia, warm, cold, and PCH, peroxisomal cold hemoglobinuria. Very important question. They may not be asked in a short note questions, but they can be asked as MCQs. They can be asked as MCQs. Which antibody is in warm? Which antibody is in cold? What is PCH, peroxisomal cold hemoglobinuria? What is PNH, peroxisomal nocturnal hemoglobinuria? Very important question. Peroxisomal nocturnal hemoglobinuria is a defect in CD55, CD9. Okay, decay accelerating factor we call. Okay, decay accelerating factor defect. So what will happen? There will be lysis. Patient again present with dark colored urine, increased risk of thrombosis. Hepatic vein will undergo thrombosis. Okay, both arterial and venous thrombosis. Paroxysmal nocturnal. Okay, whether it is an acute or a congenital condition. Remember, paroxysmal nocturnal hemoglobinuria, it is an acute condition. It is not a hereditary condition. It is an acute condition. Fine. So in RBC disorders, make sure you cover all these questions. Then coming into WBC disorders. AML, ALL, CML, CLL, must know. AML, AL, CML, CLL with clinical case scenarios, must know. Then Burkitt's lymphoma, Burkitt's lymphoma, Hodgkin's lymphoma and its various classifications. Nodular sclerosing, lymphocyte rich. Burkitt's lymphoma, Hodgkin's lymphoma, various classification important. ALL, CML, CLL important. Hairy cell leukemia important. Anemia important. Aplastic anemia important. Polycythemia vera, a child or a female from high altitude presenting with pinkish hue, elevated RBC count, elevated hematocrit. What is your diagnosis? Polycythemia vera. Polycythemia vera, very, very important question. Agranulocytosis important. Agranulocytosis important. Patient will be having a history of drug intake. Following that, he will present with a neutrophil count of 500 to 1000. What is a normal WBC count? It will be what? 4000 to 11,000. But here, the okay. So once again, I am repeating. Primary, there is polycythemia rubra vera is important. The next question, drug-induced agranulocytosis. Following some drug intake, the patient will present with reduced neutrophil count, recurrent episodes of fever, not subsiding with regular medication. It is drug-induced agranulocytosis. Aplastic anemia is important. Burkitt's lymphoma, hairy cell leukemia is important. Then coming to platelet disorders. Anti-phospholipid antibody syndrome is important. Disseminated intravascular coagulation is important. Bernard-Solier versus Glanzmann thrombocythemia is important. Hemophilia is important. There is especially hemophilia A and B. Von Willebrand disease is important. Idiopathic thrombocytopenic purpura is important. A female coming with history of recurrent episodes of bleeding associated with decreased platelet count. What is the diagnosis? It is idiopathic thrombocytopenic purpura. Remember, ITP is more common in female. The patient will be having recurrent episodes of bleeding. There will be reduced platelet count. Okay, remember it is idiopathic thrombocytopenic purpura. Disseminated intravascular coagulation, a very important case scenarios with the lab parameters I have already shared in the group. Make sure you are reading the case scenarios of platelet disorders and DIC which I have shared in the group. Hematology, don't compromise any case scenario questions. Okay, any case scenario questions you should be able to answer. So make sure you are going through all those PDFs. Then coming into transfusion medicine. As far as transfusion medicine is concerned, make sure you are reading hemolytic transfusion reaction. TRALI, very, very important question I am expecting this year. Transfusion related acute lung injury, TRALI, which occurs within 6 hours. Within 6 hours because of donor anti-HLA antibodies. Patient present with tachypnea, dyspnea, breathlessness, there will be hypotension. Okay, these are the characteristic features of TRALI, transfusion related acute lung injury. Very, very important question. Then febrile non-hemolytic transfusion reaction. Transfusion reaction as such, okay, I will share the PDF once again in the group. Transfusion reaction, we have early as well as delayed transfusion reactions. Early transfusion reaction occurs within 24 hours following blood transfusion. Delayed transfusion reaction occurs after 24 hours of blood transfusion. Okay, early versus delayed. In that, Raleigh is important. Febrile non-hemolytic transfusion reaction is always also important. Bombay blood group is important. Bombay blood group is important. Blood grouping, cross matching is important. What is minor cross matching and what is major cross matching? Very, very important. Urine examination, physical, chemical, and microscopic examination of urine. I have already shared the audio in the group. Make sure you are hearing that. If you know that point, that is enough. Physical, chemical, and microscopic examination of urine. Repeated and repeated question year after year. So transfusion reaction is important, minor major cross-matching important, Bombay blood grouping important, Raleigh important, febrile non-hemolytic transfusion reaction important, and this urine examination, physical, chemical, and microscopy important. So paper 1, chapter 1 to hematology, I have covered almost all the possible questions. Make sure you are not missing even a single question I have mentioned in this video. Okay, if you cover this much itself, you can get a very good score in both MCQ as well as your theory. All done? All okay? Okay, so can we wind up today's session? Can we wind up today's session? Paper 1, top to bottom, maximum, as far as I know, I have covered today. Okay, paper 2, we will plan it on one more day. Okay, because or else it will be, you will be feeling so more, a little bit more bored. Okay, so we will have it on one more day, don't worry. Neoplasia, once again I am repeating, P53 important, retinoblastoma important, oncogenes, the mechanism of activation important, the 7 steps in which the tumors evade apoptosis and how it producing malignancy, that is important. Sickle cell anemia confirmatory test is HPLC. HPLC, high performance liquid chromatography. Sodium metabisulfate test is just a screening test. Nestov test is a screening test for thalassemia. Again, the confirmatory test for thalassemia is HPLC. For flow cytometry, eosin 5-methylamide, that is actually the confirmatory test for hereditary spherocytosis. Osmotic fragility test is just again like a screening test. Confirmatory test is flow cytometry. Remember, flow cytometry is the confirmatory gold standard test for hereditary spherocytosis as well as peroxisomal nocturnal hemoglobinuria. HS and PNH confirmatory test is flow cytometry. Then in neoplasia, Warburg effect is important, paraneoplastic syndromes are important, hamartoma, choristoma is important, then tumor markers are important, okay, liquid-based cytology is important, FNAC of breast and thyroid is important, metastasis, essay question important, P53, RB, retinoblastoma, cell cycle, at which point it is going to act important, guardian of cell cycle, governor of cell cycle, okay, all important. Chapter 1, TGF beta is important, transforming growth factor beta is important, stem cell location is important, CRISPR is important, extracellular matrix and composition is important, hepatocyte growth factor or scatter factor is important. One more question I forgot to mention, hepatic regeneration, because following liver transplant, the liver will regenerate within 3 to 4 months. There is a definite mechanism okay, with the involvement of cytokines like interleukin 6 and all. Okay, it is mentioned, I think, in the chapter inflammation. Please make sure you are studying regeneration of liver, a very, very important question, short note question. Okay, so I think I have covered almost all possible questions in paper 1. Though infectious diseases, environmental diseases, childhood diseases, at least make sure you are going through the short notes and the questions which I have mentioned. Okay, if you read that itself, it is more than enough. So can we wind up? Yes.